Hey guys, and welcome back to Clinical Physio with me, Khalid Maidan. In today's video we're going to be taking you through active range of movement testing of the elbow joint. We're going to show you all the tests you need to complete and show you the key muscles that influence these movements too. You can also have a look at our video titled Why Test Active Range of Movement, which gives you the full clinical reasoning behind active range of movement tests. So as to not slow your video down, we're only going to be showing you the tests on one elbow. However, it's vitally important in practice that you compare the affected and unaffected sites. As with all active range of movement testing, we need to consider P, Q and R, pain, quality and range. If you're not familiar with our P, Q and R, here's a quick recap. If you do know what we mean, head on through to the main video. So as we have said, when testing active range of movement of any joint, we need to consider P, Q and R. P for pain, Q for quality of movement and R for range of movement. In terms of pain, if pain is present, we know that there is a dysfunction within this movement, which may be causing our patient's problem, and will likely direct further testing to this area to try and isolate the source of the pain. If pain is not elicited as part of the examination, the therapist can move on to the next stage. For example, if there is no pain on active lumbar spine movements during a hip examination, the lumbar spine can be ruled out of the initial investigation. In terms of quality, good quality indicates that the brain and local tissue are both happy and able to perform the movement. So what does that look like? It means that the patient will look very willing to move and have sufficient power in movement with good control and coordination. If these are lacking during the movement, quality can be questioned, and thus likely direct further testing to establish why the movement is of poor quality. For example, weakness, which could be due to a myotomal weakness from a spinal pathology, or a deconditioned muscle from the local area. In terms of range of movement, too much or too little range can indicate a dysfunction within the movement and could also help us identify the patient's condition. As a therapist, it is always important to use the range values within your movement test as objective markers and for you to compare the specific range values in each treatment session. It is important to note the range at which your patient's pain starts and the range at which the movement ends, as often these two values will be very different. For example, if we only measured the movement at which pain starts, we do not actually know how much range the patient can achieve. Essentially, a lack of range indicates that there is a stiffness or a weakness which is preventing full movement. The first thing we're going to ask Liv to do is elbow flexion. As the therapist, we're going to stand in a side-on position so that we can accurately measure the angle of flexion. Liv, the patient, is going to start with her arm in a fully extended position, and we're going to ask her to flex her elbow up towards the shoulder. After she's done the movement, we might apply some overpressure to see if this causes any increase in pain and to see what the end feels like. We may only do overpressure if the full range of movement is pain-free. There's no point in putting further stress on the joint when pain has already been elicited. So that's how we test the movement for flexion. The key muscles involved in elbow flexion are biceps brachii, brachialis, brachioradialis and pronator teres. As we said earlier, when we're testing the movement, we're looking at our P, Q and R. We may achieve pain with elbow flexion because the triceps muscle is on a stretch, because the biceps muscles are actively contracting, and because increased pressure is being placed on the cubital fossa. We're looking at quality of movement, and sometimes you may find that if patients have a problem with this movement, the movement may be jerky, or sometimes the patient may have a particular snapping alongside the medial aspect of the elbow, which is where the triceps muscle, the tendon of the triceps muscle, is flicking over the medial epicondyle. Finally, the range that we expect for elbow flexion is between 0 and 145 degrees. So next we're going to look at elbow extension. As with flexion, the therapist is going to stand to the side of the patient and the patient is in a sitting position. We're going to ask Liv to bring her elbow from a fully flexed position out into an extended position. Then we may apply some overpressure just to see if this elicits any further pain within the movement. The main muscles involved in elbow extension are the triceps muscles with minimal activity from anconeus. So let's talk about our P, Q and R. In terms of pain, we may elicit pain around the biceps area because these muscles are on a stretch. We may elicit pain in the triceps area as these muscles are actively contracting during the movement. We may also achieve pain around the joint itself, as elbow extension achieves the locking mechanism within the joint, which puts certain joint structures under stress. Next, we're going to have a look at quality. As you can see with Liv's elbow, her elbow extends into a hyperextended position as Liv suffers from hypermobility. We would normally expect elbow extension to look like that so that we achieve 0 degrees, whereas we can see with her that we go even further. This may tell us about joint structures again, as the locking mechanism is even further achieved. The other thing we may find with extension in your patients who suffer with osteoarthritis around the elbow is that they may not be able to achieve full extension, so that tells you about the quality of their movement. And finally, the range of movement for elbow extension is between 145 degrees of elbow flexion and 0 degrees of extension, or, as you saw in Liv's case, maybe even a little bit further. So now we're going to have a look at active supination and pronation, and we're going to combine these movements together when we test them. So the therapist stands in front of the patient this time so that they can accurately measure pronation and supination. The patient, as we know, is sitting. The positioning of the patient's arm before you start the movement is key. We're going to place Liv's arm in a position like this so that the elbow is flexed at 90 degrees and so that the shoulder is in a neutral position. We're going to talk about that a little bit later as to why this is important. From here, we're going to ask Liv to turn her hand all the way to the lateral side, which is supination, as if she was holding a bowl of soup. We're then going to ask her to turn her arm all the way in the opposite position, which is pronation. We're then going to apply our overpressure if we need to. For supination, you're going to place your hands, one to support the elbow and the other one on the thinner eminence of the hand to achieve further overpressure of supination. For pronation, your right hand can stay here, the other hand is now on the dorsal side of the hand and turning just above the wrist joint, or sorry, more distal to the wrist joint to achieve full pronation. So the muscles involved in each of these movements are as follows. For supination, you have the supinator muscle, brachioradialis, and biceps brachii. For pronation, you have brachioradialis, pronator teres, and pronator quadratus. You'll notice that brachioradialis is involved in both of these movements. So let's look at our P, Q, and R. P is for pain, and when we're testing these movements, for both pronation and supination, you may expect more pain at the end of range position, as this is when the radial head is fully rotated, both in a supinated position and in a pronated position. For quality of movement, a similar pattern can be caught for both supination and pronation in terms of how the patient performs the movement. We were talking earlier about making sure that the shoulder is in a neutral position. This is because when patients have a difficulty in achieving supination, you may find that they laterally rotate the shoulder to try and achieve further movement. And you may find that if they struggle with pronation, they may medially rotate the shoulder more. So certainly have a look at that in terms of quality. The other thing to look at is a varying range of elbow flexion and extension when performing the movement, which is why you want to make sure that the elbow is in a flexed 90-degree position. You may see your patients when they have difficulty with supination either extending the elbow further to achieve the movement, and in a similar way they can do the same with pronation. As for range of movement for both of these tests, supination varies between 0 and 85 degrees, whereas pronation varies between 0 and 70 degrees. So finally, we're going to complete our active range of movement assessment by looking at wrist flexion and wrist extension. And the reason we focused on these two particular movements of the wrist is because they have a large influence on two very specifically elbow-based conditions. And those two conditions are lateral epicondylitis, also known as tennis elbow, and medial epicondylitis, also known as golfer's elbow. So now we'll take the therapist and patient position for how we're going to do these tests, and the therapist is going to hold the patient's hand like so that the elbow is clear. The elbow is positioned
with support and the wrist is clearly exposed. This is a good position to do these tests if you're quite happy that your patient is comfortable having done the extension, flexion, supination, pronation tests. If you're worried about the patient's pain levels because they have quite irritable pain levels, or you want to try and give them more comfort, you may be able to place them on a chair sitting with their elbow rested on the plinth, maybe with some pillows for extra comfort. So now we're going to look at the movements themselves. I'm going to ask Liv to bring her wrist into a fully flexed position like so, and then into a fully extended position like so. We may also choose to look at overpressure for wrist flexion. We do this like so, placing the patient's wrist into flexion with the therapist hand on the dorsal aspect of the hand, distal to the wrist joint, and then in an extended position with the therapist hands on the palm, pushing downwards, again with therapist hand distal to the wrist joint. So those are the movements themselves. On the screen, you'll see the muscles that are involved in wrist flexion and wrist extension because there are a lot of them. So here are the wrist flexor muscles, and now the wrist extensor muscles. So now we're going to look at P, Q and R in terms of wrist flexion and wrist extension. So when the patient is performing wrist flexion, you may expect to find pain in two particular places, which is the medial epicondyle and the wrist flexor muscles on the anterior side of the forearm. This is because of the close relationship between active wrist flexion and medial epicondylitis. However, in terms of wrist extension, the two places you may find increased pain are the lateral epicondyle on the lateral side of the elbow and the posterior muscles along the forearm, as the close relationship with lateral epicondylitis is with wrist extension. Next, we're going to look at Q, and in terms of quality of movement, the thing to look for is when the patient is doing their wrist flexion and extension, notice how much the joint is moving at the wrist as opposed to the fingers, as increased finger movement can give you a more deceptive sign of how much the patient is moving. And finally, we're going to look at R. In terms of wrist flexion, normal range is between 0 and 75, and in terms of wrist extension, normal range of movement is between 0 and 70.
So let's summarise this video on active range of movement of the elbow with our key points. First, start your assessment by clearing the shoulder and potentially the neck if your patient presents with signs such as paresthesia in the arms. Then, complete your assessment of the patient's active range of movement within the elbow, as well as active wrist flexion and extension. Make sure you are testing both the affected and the unaffected sides. And when looking at your active range of movement, look for P, Q and R. P for pain, Q for quality of movement, and R for range of movement. And that completes our video on active range of movement testing of the elbow joint. In practice, you would now compare your patient's active range of movement with the passive range of movement at the elbow joint. And by comparing the two, it will allow you to make a decision as to whether it's most likely to be contractile or non-contractile structures which are at fault for their condition. This, as well as your other tests, should help you clarify their diagnosis. If you're not quite sure on how to interpret the difference between active range of movement and passive range of movement, you can always look at our additional videos titled Why Test Active Range of Movement and Why Test Passive Range of Movement. So head on to those and join us back again here on Clinical Physio. Thanks for watching, and we'll see you again soon.